Igor, and today we will go talk about granulomatosis with polyangiitis. Granulomatosis with polyangiitis is a type of systemic ANCA-associated vasculitis of a small and medium-sized vessel characterized by necrotizing granulomatous inflammation, and is typically affected the lungs, paranasal sinuses, and kidneys. Epidemiology more in men than women, peak incidence before 40 to 60 years, and prevalence 3 cases per 100,000. Etiology idiopathic. The following processes plays a key role in the pathophysiology of granulomatosis polyangiitis. Aberrant epigenetic expression of proteinase 3 on the cell membrane of neutrophils. Formation of antibodies against proteinase 3. Binding of proteinase 3 ANCA to proteinase 3 activates neutrophils. Release of neutrophilic inflammatory mediators and formation of neutrophil extracellular traps. Complement activation and damage of endothelial cell of small blood vessels. Clinical features include the constitutional symptoms: fever, night sweats, weight loss, arthralgia. Often the first clinical manifestation of this disease is chronic rhinitis and sinusitis, nasopharyngeal ulceration, and nasal septal perforation, saddle nose deformity, depression of the nasal dorsum, chronic otitis and or mastoiditis. In some cases, thick purulent discharge sometimes contain blood. Oral ulcers. Strawberry gingivitis and characteristic feature of granulomatosis with polyangiitis is characterized by painful erythematous gingival inflammation with petechia that results with appearance of the surface of a strawberry. Clinical features: lower respiratory tract, potential life-threatening, treatment-resistant pneumonia-like symptoms with cough, dyspnea, hemoptysis, wheezing, hoarseness, and/or pleuritic pain. Clinical features of pulmonary fibrosis, pulmonary hypertension, and/or pulmonary hemorrhage may occur. Renal involvement is potentially life-threatening. Pauschi immune glomerulonephritis. Pauschi immune indicates that there is little evidence of immune complex and antibody deposits that lead to rapidly progressive crescentic glomerulonephritis with possible pulmonary renal syndrome. Typical causes hematuria and red cell casts. Clinical features include skin lesion is papules, vesicles, ulcers, purpura of the lower extremities may lead to necrotizing vasculitis of small vessel and dry gangrene of the digits. Ocular involvement include conjunctivitis, episcleritis, retinal vasculitis, and corneal ulceration. Classic granulomatosis polyangiitis triad is necrotizing vasculitis of small arteries, upper and lower respiratory tract manifestation, and glomerulonephritis, and cardiac involvement is potentially life-threatening. Pericarditis, myocarditis, vasculitis of the coronary arteries may lead to myocardial infarction and death. Rare cardiomyopathy. Upper respiratory manifestations include purulent, sometimes bloody discharge, chronic nasopharyngeal infection, saddle nose deformity, and the most common chief complaints. Diagnosis. Routine studies include inflammatory markers, increased erythrocyte sedimentation rate, or increased C-reactive peptide. Complete basal count, there's normocytic, normochromic anemia, basal metabolic panel, increased creatinine and BUN, and urinalysis we see microscopic hematuria, proteinuria. Urine sediment include nephritic sediment, dysmorphic red blood cell, and red blood cell cast. Serology: antineutrophilic cytoplasmic antibody, proteinase 3, and myeloperoxidase O. Myeloperoxidase. anti-neutrophilic cytoplasmic antibody. Imaging studies obtain a chest X-ray or CT chest. Supportive finding: multiple bilateral cavitating nodular lesion, pulmonary hemorrhage. Indication: considered in all patients to confirm this diagnosis. Biopsy. Finding: necrosis, vasculitis of small and medium-sized vessel, intravascular and extravascular granulomas, mainly in the lungs and upper airways. Renal tissue, PVC, immune focal and segmental necrotizing glomerulonephritis. It's on X-ray of the lung synodular lesion that may be in granulomatosis with polyangiitis and hemorrhage, maybe hemorrhage and um, nodular lesion we also see, and this is biopsy in patient with granulomatosis with polyangiitis. General principles of treatment is plasmapheresis that is may be considered in certain patient and patient with concomitant anti-glomerular basement membrane disease. And also non-severe disease treatment include glucocorticoids plus a glucocorticoid sparing agent, for example, methotrexate, Prefior, or azathioprine. And severe disease, organ or life-threatening, we include glucocorticoids plus or glucocorticoid sparing agent, for example, rituximab or cyclophosphamide. Maintenance of remission is lower taper glucocorticoids to the minimal effective dose. Glucocorticoid sparing agent is rituximab, Prefior, methotrexate, or azathioprine. Duration of treatment is typically more than 18 months. Supportive care: monitor for adverse effect of immunosuppressant. Consider pneumocystis pneumonia prophylaxis. Thank you. Subscribe to the channel.